Okay, let's get this started. So today we're going to talk about renal disorders across the lifespan. Um, Welcome, new person. And so when you think about renal pathophysiology, we're really talking about how the kidneys tell the story of the body's internal environment. So the kidneys are not just filters, they're strategic decision makers. So every time blood passes through them, they're negotiating between volume and concentration, right? We're negotiating between acid base, between keeping and letting go. So the goal today isn't to memorize isolated cases and diseases, it's to understand patterns. And this whole lecture has been all about pattern recognition. How do you recognize a renal problem, categorize it quickly, and then prepare the patient either for definitive care nephrology consult with clarity if needed. So across the lifespan, these patterns shift. A dehydrated infant, a pregnant woman, someone with preeclampsia, an elderly man with congestive heart failure, all might show elevated creatinine, but for entirely different reasons. So by the end of the session, you should have a working vocabulary for evaluating renal function and differentiating prerenal from intrinsic, from postrenal disease, and identify what the red flags are that demand urgent referral or intervention. You want to think of this as like a clinical reasoning map for any renal presentation, whether you're in primary care, acute care, or managing complex disease across the lifespan. So I'm going to begin first by reviewing renal functional anatomy, not to memorize parts though, just that you understand the logic of a nephron. And every segment has a distinct voice, filtration at the glomerulus, concentration in the tubule, acid base fine tuning in the collecting duct. And when you interpret a lab or urine sediment, you're essentially translating what the nephron is trying to tell you. So we're going to practice some syndromic bucket thinking. Any renal presentation, no matter how messy, can usually be put into one of four patterns, either glomerular, tubular, vascular, or postrenal. So if you can name the syndrome, then you can predict the labs, the symptoms, and the management priorities as we move through this. Then we're going to differentiate and manage acute kidney injury from chronic kidney disease across the lifespan. And like, for example, a creatinine of 1.6 means something very different in a muscular 25-year-old than it does, say, in an 80-year-old woman with sarcopenia. The key is to interpret the values in context, not in isolation. And then I'm also going to highlight some pediatric, pregnancy, and geriatric things to take note of because kidney physiology shifts with age and circumstance. So, like infants are prone to prerenal states, pregnancy tends to introduce hyperfiltration and unique hypertensive risks. Older adults tend to lose autoregulatory precision. And then finally, I have to keep letting people in this class. Finally, I'm going to walk through some practical clinical scenarios that teach you when a condition can be confidently managed within your scope of practice and when it's time to involve nephrology. That decision of when to watch and when to act and when to call, that's the essence of what we're going to do for this lecture today. And hopefully what you do as you go forward in practice. So as we go through each section, you need to keep asking yourself, what is the dysfunction? And what is reversible and what requires special intervention. This is the mindset that turns your renal problems into some puzzle that you can possibly solve, or at least move the patient in the right direction. All right, so let's talk about renal functional anatomy. Now, before we talk about disease, we got to talk about these different areas of the kidney. The upper urinary tract is the kidneys, the calyces, the renal pelvis. This is where filtration and concentration occur. This is the site of most renal pathology. The lower urinary tract includes the ureters, the bladder, and the urethra. This is a primary drainage system. Problems here This causes things like obstruction, retention, infection. These are technically not intrinsic renal problems. These are post-renal occurrences and situations. There's also a functional sequence to every renal process. There's filtration, tubular transport, and excretion. Filtration happens at the glomerulus, and this is where plasma is filtered through a semi-permeable membrane. Hang on to that semi-permeable membrane, because when we talk about dialysis, we use something else as a semi-permeable membrane to do the filtration process because the kidneys have failed. Tubular transport, this refers to selective reabsorption and secretion along different nephron segments. And finally, excretion is the elimination of what the body has decided to discard. Now, when a patient presents with abnormal renal labs, you always have to start asking where in this sequence, filtration, tubular transport, or excretion, is the problem. A filtration problem will point you to something like glomerular disease. A transport problem suggests tubulointerstitial dysfunction. A drainage problem will indicate something like a postrenal obstruction. That's the basic map of kidney disease. Glomerular disease, tubulointerstitial dysfunction, postrenal obstruction. That's the basic map where you can then localize and decide whether it's something you need to manage, consult, or deal with in another way. Okay. So now that we've covered where the kidney operates, I'm going to outline what actually is happening in measurable physiological terms. So about 20% of the cardiac output passes through the kidney each minute. The glomeruli filter plasma based on size and charge, keeping cells and large proteins in circulation, and then we allow water and small solutes to pass through the nephron. Any process that alters this barrier, like hypertension, diabetes, immune injury, these are the changes of what shows up in the urine. So tubular reabsorption and secretion, this happens after the filtration process. About 99% of the filtrate is reclaimed. Sodium, glucose, bicarb, and water are reabsorbed in specific nephron segments. Hydrogen, potassium, and certain drugs, these are secreted back into the lumen, and this step determines volume status, electrolyte balance, and acid-base control. The kidneys also offer an endocrine function. The kidneys they're involved in the RAS system that we talked about last time, the renin-aldosterone system, which regulates blood pressure and sodium retention. And also the kidneys secrete a hormone, EPO, erythropoietin, and this stimulates red cell production in response to renal hypoxia. So if the kidneys feel deprived, they kick into action, and the goal is to make them feel less deprived. So remember last week we talked about the low flow state triggering the RAS system to get the blood pressure up in order to perfuse the kidney better? Well, the same thing. Remember, part of perfusion is there enough hemoglobin getting to the kidney? If the kidney feels deprived of oxygen, it's going to stimulate EPO production to make more red blood cells. The other thing is the kidney converts 25-hydroxyvitamin D to its active form, calcitrol, which is essential for calcium and bone metabolism. That 25-hydroxyvitamin D, that's the lab value when we're checking people's vitamin D level. The other thing that the kidneys do is they maintain fluid and electrolyte and acid-base balance. These are the combined mechanisms that the kidney maintains extracellular fluid, volume, and serum osmolarity, and they also control pH within this very narrow limit. So when a patient presents with abnormal labs, hyponatremia, metabolic acidosis, anemia, secondary hyperparathyroidism, you need to think back to which of these 4 kidney functions has been disrupted. Localizing the dysfunction is the first step in determining whether it's reversible physiologic or this is an issue with established renal disease. Okay. Now, when you evaluate a renal problem, you need to start by assigning it to one of four syndromic buckets: either glomerular, tubulointerstitial, vascular, or postrenal. The problem is going to be in one of these four buckets. This is the structure that helps you decide what data you actually need in order to confirm the mechanism. So if you're in bucket one, a glomerular problem, filtration barrier injury is what you're thinking about. You're looking at things in the UA like hematuria, proteinuria, red blood cell casts. If you see those things, you're thinking glomerular problem. Think nephritic or nephrotic process. In the tubulointerstitial or the interstitial damage stage, you're going to see a more mild form of proteinuria, white blood cell casts, impaired concentration. So that'll be manifested by looking at the specific gravity. This is often due to things like ischemia, toxins, or allergic inflammation. So depending on the value you're seeing, you're able to visualize and figure out where in the kidney is the problem. If your problem is vascular, you're talking things like perfusion or small vessel injury. This is where you will see things like an abrupt GFR decline, or maybe you'll see resistant hypertension. This is a vascular injury problem causing renal dysfunction. This is the person where you're going to do things like renal Dopplers and vasculitis serologies if you're suspecting, because you want to know how well perfused the kidney is. Finally, if you're in the postrenal bucket, this is where we're dealing with obstruction along the outflow tract. This is fluctuating urine outputs, rising creatinine. This is where renal ultrasound and post-void residual and urodynamic studies will give you the biggest bang for your buck to clarify this problem. Once you've localized the category, you can confirm or rule it in or out using various renal indices. And the most popular renal indice here, besides electrolytes, potassium, bicarb, sodium, anion gap, etc., urine osmolality, that is a major indicator of what's going on. So it's concentrated if it's greater than 500 in a prerenal state. There is something called isothenuric, and that's in a renal tubular injury. The other index you're looking at here is called the fraction of excreted sodium. This test determines what percentage of filtered sodium is excreted in the urine. I will not ask you to calculate this on a test, but I will ask you to tell me what it means. The reason you don't need to calculate it is if you download that app, MD Calc, it has a lot of those clinical calculators in there. It's free. It will tell you what numbers to enter to spit out a value. But what I want you to know is, what does this number mean? And conceptually, what is this test for? So this test determines what percentage of filtered sodium is excreted in the urine. The concept here is that the fraction of excreted sodium quantifies the percentage of filtered sodium that's ultimately excreted in the urine. It reflects tubular handling of sodium and helps determine whether renal hypoperfusion or tubular damage is the reason for the acute kidney injury that you see the creatinine for being bumped up. So if you get a fraction of excreted sodium of less than 1%, and you can see what the parameters are there for doing this. It's a plasma sodium times a urine creatinine times the quantity of a urine sodium times a plasma creatinine. So you're drawing them at the same time. You'll get those four values times the factor of 100. That gives you the fraction of excreted sodium. If it's less than 1%, that's a prerenal state, right? This means that the kidneys are slow and low flow, and they're going to respond appropriately by reabsorbing sodium. So it's less than 1%. They're trying to hang on to that sodium so they have more water fluid in circulation, so they're reabsorbing sodium. That means tubular function is intact because it's able to reabsorb the sodium. So there's less than 1% sodium in the pee. Then there's a fraction of excreted sodium of greater than 2%. This is intrinsic. This tells you there's tubular. Acute kidney injury has gone on here. That's the reason. It's not that they're hypoperfused, is there's acute injury here. So the tubules are damaged and can't reabsorb sodium efficiently. So more sodium is lost in the urine. So that's the easy one. Less than 1% prerenal, greater than 2% intrinsic. The fraction that goes between 1 and 2%, this is the indeterminate zone. This evolves, this is like something is going on. We could be going from prerenal to acute tubular necrosis. You made a problem and it's getting worse. That's in the 1 to 2 range. We're heading in the wrong direction. Now, diuretics, you need to be careful with this because this changes our interpretation a bit. Diuretics artificially increase sodium excretion, which can falsely elevate the fraction of excreted sodium in patients on diuretics. So you have to use, there's a new formula. I'm not going to ask you this. This is part of that nice to know, fraction of excreted urea. But in general, you should just know that the diuretics are going to affect this FeNa. They call it the FeNa score. And just for your own knowledge, a fraction of excreted urea less than 35% still indicates prerenal issues. Fraction of excreted sodium is most useful when the baseline renal function is known and the urine sample is collected before you give them fluids or diuretics, because that will affect, you could dilute them and then also falsely make it low. Okay. So practically, how do you do this? You order a serum sodium and a serum creatinine. If you work in renal or hospital medicine or post-surgery, this is useful information. You can take this to the bank tomorrow. Order a serum sodium and a serum creatinine. Those are routine basic metabolic panel labs. But you're also going to collect a spot urine sample, not a 24-hour urine, a spot urine sample for urine sodium and urine creatinine. You'll get those values and put them into this equation, and that's what's going to give you the index you're looking for. The lab will report all 4 values, and then you will be able to figure out which bucket your patient belongs in. All right, so let's apply our framework to a glomerular case. So this patient is a 45-year-old man who presents with foamy urine and ankle swelling. So step 1, we need to identify the key abnormality here. The key abnormality here is the foamy urine, because that's suggesting to you proteinuria, which means a loss of integrity in glomerular filtration barrier. The endothelium, the basement membrane, and the podocyte foot process, these are where the barrier leaks can occur. Albumin spills into the urine, lowers the plasma oncotic pressure, and causes dependent edema to form. So that's what you're seeing, or what you should be thinking about when you see foamy urine. Step 2 is define the syndrome. Is this nephritic or nephrotic? And the difference is what? Well, nephritic is an inflammatory injury. You will see in nephritic syndrome hematuria, red blood cell casts, hypertension, and mild to moderate proteinuria. The big number here is, and pay attention to this, less than 3.5 grams a day. Less than 3.5 grams a day, nephritic. If they're greater than 3.5 or greater, we're going to call that nephrotic syndrome. And nephrotic syndrome is a non-inflammatory basement membrane injury. This is causing heavy proteinuria. Usually you will see hypoalbuminuria because most of the protein you're seeing in urine is albumin. So for some reason it's being peed out. That's a big molecule. You may also see hyperlipidemia and edema. Now, the patient's foamy urine and ankle swelling is what's pointing you towards the nephrotic range proteinuria without even drawing a test. You're thinking that because to get to that level, you need a lot of protein to make that foam. It looks like beer. If the pee looks like beer, that's a concern. Meaning after it settles, it still looks like beer. The next thing you want to do is you want to quantify protein loss. So you use a 24-hour urine protein collection, or you can do a spot urine to protein to creatinine ratio. That's called a UPCR. or albumin to creatinine ratio, ACR, UACR. Those are spot tests nice to do. The most accurate is the 24-hour urine. If they're in the hospital overnight, do it. If you can trust them to do it at home, do it. But you remember, the 24-hour urine has very specific instructions, right? You waste the first one of the day, you collect it all up until the first one of the next morning. If you screw up that ratio, or if you don't catch every drop of pee, you're going to have results that are not reliable. So the spot urine testing is useful. Now, there are some supporting labs when you're working up this kind of situation. A comprehensive metabolic panel will give you what their albumin and total protein are. If that's going down because it's all going in the pee, that further bolsters your suspicion. A lipid panel is normally done to detect secondary hyperlipidemia. This problem occurs a lot with hyperlipidemia, so sometimes a treatment is two-pronged where you're aiming at bringing down the lipids. Urine analysis with microscopy, this is very commonly done. We neglect the microscopy bit. It's easy enough to order when you're doing a UA. But what the microscopy is going to tell you is you're looking at RBCs, RBC casts, oval fat bodies, which are detected only under polarized light. So only if they see them will they report them to you. It's not like it comes out on a strip. So what happens is you can order a UA and you can check either with microscopy, or what's better and better priced is reflexive microscopy. So what that means is if it sees something abnormal on the UA, it will automatically trigger the microscopy so that they can go through and filter and you'll know exactly, rather than having to bring the patient back and recheck and send to the lab and wait again. Now, there is another condition, a common nephrotic etiology called minimal change disease. This is usually an immune-mediated podocyte injury causing a foot process effacement and an electron microscopy visualization. So what happens is this is something that's common in children, but it can occur in adults. Sometimes it's triggered by too much NSAID use or, God forbid, lymphoma. This presents with sudden heavy proteinuria and normal renal function. So there's another thing. When you see an abnormality in one and you don't see the expected abnormality in other labs, that should raise a red flag of this is not presenting in the typical fashion. I expect foamy urine to have other abnormal labs to go with it. If you don't, that should say something special is going on here and I need to investigate. This is highly responsive. Minimal change disease is highly responsive to corticosteroids. But obviously, if you find this, you have enough information for the referral to get them to definitive care. There is another condition called focal segmental glomerulosclerosis. This is patchy scarring of some of the glomeruli. It can be primary or secondary in things like obesity, hypertension, HIV, sickle cell disease. So when I tell you what those secondary causes are, immediately you're thinking, well, what's the unifying factor in those conditions? This is common in adults. It's often steroid resistant, and this can progress to chronic kidney disease. So recognizing these patterns will help you know when to start conservative measures like sodium restriction, ACE inhibitor therapy for proteinuria, or when to refer to nephrology for a possible kidney biopsy. So, and then finally, the last step here is this will localize which glomerular bucket for you. So you're going to confirm the nephrotic range proteinuria, evaluate for systemic causes before labeling it idiopathic. You can have idiopathic proteinuria. Any patient with proteinuria more than 1 gram in a day with nephrotic features, with coexisting hematuria, that's a person that's going to go for a nephrology consult. Okay, that's kind of like your chain of events there. Greater than 1 gram a day, nephrotic features, coexisting hematuria, consult nephrology. Okay. So now we're going to talk about acute kidney injury. Abbreviated AKI. AKI basically is referring to a rapid decline in kidney function, developing over hours to days. Results in decreased glomerular filtration, accumulation of nitrogenous waste, and electrolyte imbalances, and the loss of fluid regulation. So that's the picture of acute kidney injury. It's important to remember that acute kidney injury is not a diagnosis by itself. This is a syndrome indicating to you that something has impaired the renal function. The core question here is, how acute is this? When did the creatinine begin to rise? What is the mechanism? What is the mechanism? Is this a prerenal, meaning a perfusion related? Is this intrinsic parenchymal injury? Or is this postrenal obstruction causing the rise in creatinine? The other question you're always dying to know is this reversible? Because timely intervention often determines the recovery. Acute kidney injury is common, and up to 20% of hospitalized patients have this. But many cases are preventable if recognized early. The case I just saw today, the woman went into the hospital with abdominal pain. She was dehydrated. She was somewhat hypoxic. So they decided they would give her a contrasted CT scan. Well, what do you think that did? Acute kidney injury. That pushed that creatinine to 3, pushed her potassium to 5.8, right? She is now worse off having not met these people. So now, not only does she have a PE, she has acute kidney injury and possibly a peritoneal cancerous mass, which explains the big belly, but she's going to die a lot faster from the acute kidney injury than she is from the metastatic cancer. Now, this is classified according to guidelines of a society. And the society's guidelines are called Kidney Disease Improving Global Outcomes, abbreviated KDIGO. If you work in nephrology, this will be familiar. If you don't work in nephrology, you just know that this exists, and this is how they're arriving at their consensus statements. This is an international standard for just defining and staging acute kidney injury. Now, there are 3 major etiological categories. I told you this before, but I'm repeating it so that you get stuck in the habit of, you say kidney, what do you mean? You mean prerenal, intrinsic, or postrenal? So now we're going to talk about how to distinguish them and what we're going to do as we move through this. So let's define acute kidney injury. So this is an abrupt fall in the glomerular filtration rate, and that's the rate at which what? Plasma is filtered through the kidneys. That's what we mean by GFR. And it's occurring within 7 days or less. So 7 days or less is the defining criteria for acute kidney injury. The KDGI guidelines provide the international standard for defining this, and it's based on changes in the creatinine and the urine output. And they have 3 stages, stage 1, stage 2, and stage 3. Kind of catchy, huh? So when you say stage 1 kidney injury, you're talking a creatinine of 1.5 to 1.9 times the patient's baseline, or an increase of 0.3 within 48 hours. So that gives you better context. If they are normally living at a 0.5 creatinine and it goes up to 0.8 or 0.9, still within the normal range, you may have an acute kidney injury. Stage 2 is serum creatinine rise of 2 to 2.9 times the baseline, and stage 3 serum creatinine 3 or more times the baseline, or reaches 4 at the first hit, or they need dialysis, renal replacement therapy. Those are other outcomes that you can use to stratify how bad the kidney injury is. Now, when you differentiate the causes of AKI, you always think in terms of location. So prerenal, before the kidney, perfusion problem, dehydration, hemorrhage, heart failure, shock, prerenal. Intrinsic, within the kidney itself, affects the glomeruli, the tubules, the interstitium, okay? Toxins. Postrenal, after the kidney, due to obstruction of urine flow. The location of the mechanism will determine the reversibility, by the way. So a prerenal problem can often be corrected if you treat it early enough, while intrinsic damage like acute tubular necrosis, that's going to take weeks to recover and could conceivably progress to chronic kidney disease. So in practice, you're going to trend the creatinine and trend the urine output. Very low tech to measure urine output, but it's really important. And this is not the same as just measuring weights, because measuring volume is also necessary. And also, clinical context is very helpful to stage the acute kidney injury. You're trying to identify where in the system the flow is being interrupted. No, you don't need to memorize these numbers. You should generally be familiar with them. Okay. So let's look at prerenal. So this is a problem of renal hypoperfusion, reduced blood flow to the kidneys, but without structural damage to the kidney itself. The glomeruli and the tubules here are intact. The kidneys simply are not getting enough circulating volume or effective pressure to filter properly. If recognized and corrected early, prerenal acute kidney injury is completely reversible. The key lab findings here is you're going to see a fraction of excreted sodium of less than 1%. The kidney senses low perfusion and then avidly tries to retain the sodium to conserve volume. Another thing you'll see here is this BUN to creatinine ratio will be greater than 20-1. In low flow states, urea is passively reabsorbed with water into the proximal tubule, while creatinine is not. So the widened ratio here signals enhanced reabsorption rather than true parenchymal injury. Another thing you might see is a urine osmolality of greater than 500. The urine here is concentrated. When you think concentrated, think dehydrated, too many solutes in the urine. That's why it's concentrated, greater than 500, because there's antidiuretic hormone here is active, trying to preserve volume. Because remember, this is a low flow state. The body's trying to keep flow. Common causes are things like CHF, decreased effective forward flow through the heart, real hypovolemia, like you hadn't had a glass of water in 3 days and you only drink coffee and wine, and you wind up in the emergency room with a blood pressure of 60/40, tacking away to 120, and after 7 liters of fluid, you're still orthostatic. Sorry, this isn't Tell Us Our Sins Day. Okay, never mind. That happened to me about 15 years ago. Boom, in the night. A GI bug that I thought I got ahead of myself by giving myself IV hydration in the home, gave myself MAG, gave myself Pepsid, gave myself Zofran. And I was like, all right, I didn't vomit. I got this. I'm good to go. And I went to work Monday and I went to work Tuesday and I woke up early Wednesday morning and proceeded to pass out and 911 to the ER. I called out sick from the, hi, I can't come in. I'm down here in the emergency room. I'm on my 6th liter. I'm still not making it. So suffice it to say, prerenal insufficiency. Okay, so that's one way to have a low flow state. Also, overdiuresis is another way to do this. You get a little too aggressive with the Lasix. You can cause a low flow state as well. Sepsis, obviously, you're in a distributive hypoperfused state. Cirrhosis, when the liver's failing, third spacing, and low effective arterial volume. That's another way to get acute prerenal insufficiency here. The hallmark of prerenal acute kidney injury is that restoring perfusion fluids, addressing the shock, optimizing the cardiac output, normalizes the kidney function in about 24 to 48 hours. So that kind of gives you a timeline as to when you can expect things to get better. If uncorrected, though, ischemia can progress to acute tubular necrosis. And this shifts the problem now to an intrinsic problem. So pre can become intrinsic. Now, when you encounter a rise in creatinine, always start by asking this question. Is this a perfusion problem that I can correct quickly? That question alone can prevent many cases of permanent renal injury. Okay, let's take a look at this prerenal case here. So take a look at this labs regarding the previous, regarding the slide here. This is a 82-year-old woman in a nursing home with congestive heart failure who recently was over-diuresed and now has a rise in her creatinine from 1.2 to 2.0. Step 1, you need to recognize the pattern. The BUN to creatinine ratio here is 20-1. This indicates increased urea absorption from reduced renal perfusion. So now we want to look at what is the fraction of excreted sodium. It's 0.4%. The kidney is avidly trying to reabsorb sodium. And again, this is consistent with a hypoperfusion state. Note the urine osmolality here of 600. This is highly concentrated urine, showing intact tubular function and active antidiuretic hormone response. Together with these findings, what you're confirming is a prerenal pattern. There's decreased renal blood flow without parenchymal damage. Now we have to identify the cause. Well, in this patient, obviously, aggressive diuresis has reduced the intravascular volume and cardiac output. So even though the total body fluid may be high in the form of CHF, the effective circulating volume to the kidney is low. Over-diuresis has lowered the effective circulating volume in that patient. So the kidney's interpreting this as hypovolemia, slows the filtration through the kidney. The CHF worsens the problem because the forward flow of that pump is also impairing kidney perfusion. So what do we do next? Well, the first thing you need to do is stop offending the patient. Hold or reduce the diuretics, and then assess true volume status with blood pressure, orthostatics, mucous membranes, jugular venous pressure, daily weights, and the like. If they are clinically dry, you can give small amounts of isotonic saline bolus, 250 to 500 mLs, and reassess the renal function and a lung exam. You don't want to drown the patient in saving the kidneys. When I worked in CTICU, we used to have a saying, dry lungs are happy lungs and wet kidneys are happy kidneys. And sometimes in the process of wetting the kidneys, you'd fill up the lungs, and that's really bad. So we said airway, breathing, circulation takes priority, and so we would focus on the lungs. And sometimes we would have to split the difference at chronic kidney disease. If the volume overloaded but poorly perfused, then the next thing you want to do in the CHF patient is optimize the cardiac output. So maybe you review the medications, consider inotropy or afterload adjustment. What you're going to monitor here for is you need to repeat the creatinine and the urine output within 24 hours. Improvement will confirm a prerenal process if you optimize the cardiac function. Failure to improve, if they don't get better with these interventions, then you need to start thinking about, did this prerenal state evolve into an intrinsic tubular injury? So the key takeaway here is prerenal acute kidney injury is often reversible when recognized early. Always, is the kidney underperfused, and can I correct it safely? That's the question that prevents many of these from progressing to tubular necrosis. So now we're going to move into intrinsic, and we're going to talk about these three pathologies, ATN, AIN, and GN. Okay, so ATN, the most common subtypes of acute tubular necrosis, acute interstitial nephritis, and glomerulonephritis. These are the most common causes of intrinsic renal disease. So acute tubular necrosis, this is the most frequent cause of AKI, and it's caused by ischemic injury after prolonged prerenal hypoperfusion or nephrotoxic injury from drugs like aminoglycosides, radiocontrast, cisplatin, myoglobin from rhabdomyolysis. All of these things can damage the kidney. The poor woman I saw this morning has developed ATN from the contrast they gave her in her prerenal state. It's like, come on. Really, people? You didn't think of this? The hallmark finding in this case, by the way, is muddy brown granular casts or an urine analysis. So here, the tubule can't reabsorb sodium efficiently. So the fractional excretion of sodium is usually going to be greater than 2%. Recovery for this condition takes days to weeks, depending on the extent of injury. So these patients often need careful fluid and electrolyte management, which they were not doing to this woman with her potassium of 5.8 at 4:30 in the morning. And here we are at 2 o'clock in the afternoon and no one checked. I'm writing a letter at the end of this lecture. I'm going to attach this lecture and send it to that doctor and say, hey, maybe you should review. Acute interstitial nephritis. This is an immune-mediated reaction that targets renal, interstitium, and tubules, most often drug-induced. Common offenders in this category include things like antibiotics, the penicillins, the cephalosporins, NSAIDs over long-term use, non-steroidal anti-inflammatories, and proton pump inhibitors. Takes a little longer to get to this point. This is the classic triad, though not always present. If you see a fever, rash, eosinophilia with white blood cell casts, and eosinophiliuria, in the urine analysis, you want to think about stopping the offending drug. That's the primary treatment here. Corticosteroids are sometimes used if the renal function fails to cooperate. The third mechanism of injury here is this glomerulonephritis. Now, this represents an immune-mediated inflammation of the glomeruli. The urine analysis shows red blood cell casts and often dysmorphic RBCs. Some forms show low complement levels, such as lupus nephritis or post-streptococcal glomerulonephritis. Because glomerular injury involves the filtration barrier, you also may see varying degrees of proteinuria and hypertension. Intrinsic acute kidney injury tells you there is a structural injury. The kidney cannot auto-regulate or recover by restoring flow alone. The management shifts from volume resuscitation to stopping the insult, correcting the contributing factors, and supporting recovery. So always remember the following. Acute tubular necrosis, think ischemia, toxic insult, muddy brown casts. Acute interstitial nephritis, think drug reaction, white blood cell casts, rash, eosinophils. Glomerulonephritis, think immune inflammation, red blood cells, complement is down in some types. These urinary findings are the clinical clues that are going to help you localize where in the nephron the injury is happening and guide whether nephrology involvement and renal biopsy is needed. If you're at this point, by the way, if you're having acute kidney injury, nephrology is needed. By the way, nephrology was following this patient and they were nowhere to be found in the process. I'm a little angry still, hoping the K is lower. Okay. Now let's talk about this case here of a 28-year-old person minding their own business, suddenly finding themselves with acute kidney injury because, say, this person had septic shock and became oliguric, and they're producing very little urine despite receiving fluids. That should be a sign. This setup immediately tells you that there's a story here of tubular injury. The kidneys are being perfused, but they're not responding. It's like saline's going in, like, I can't hear you. La, la. That's what the kidneys are doing, okay? So this is the first red flag that isn't prerenal anymore. This is not a prerenal problem. Houston, we have a problem. It's intrinsic. So step one, let's interpret the data. You have a creatinine rise from 0.9 to 3.2 and a rapid fall in the glomerular filtration rate, okay? Now, what else is going on here? Well, the fraction of excreted sodium is 3%. These tubules are no longer reabsorbing sodium. They've gone on strike. They've lost regulatory function, okay? And the urine osmolality is what? 280. This is roughly equal to plasma. And so when the urine and the serum osmolality is equal to plasma, that is what we call asthenuria. That's a Jeopardy phrase. You'll never see it in clinical practice. If I want to flirt with nephrology and make them think I'm wonderful and great, I start using terms like asthenuria. And they're like, oh, okay, I'll come see your patient. Clearly, you know a little more than the average person. So this means that the tubules are neither concentrating nor diluting. That's what that means. That's what ISO means, right? They're neither concentrating nor diluting. Now, the urine analysis here will show muddy brown granular casts. That's the hallmark of acute tubular necrosis, by the way. So what's the hallmark of acute tubular necrosis? Might you see that somewhere? I'm going to say, oh, muddy brown granular casts, acute tubular necrosis. Step two. The mechanism. So acute tubular necrosis represents cellular death of the tubular epithelial cells. That's really what we're talking about. It's in the name, necrosis. Something has died after a sustained ischemic or toxic insult. Something has killed it off. Acute tubular necrosis, something has died. Think of it this way. In prerenal acute kidney injury, the villain is the low perfusion, but the kidney still fights back by trying to conserve sodium and water. In acute tubular necrosis, the hero mechanism fails. The tubules are damaged. Sodium is leaking back into the urine. It's like, I can't do anymore. And the sodium's going back into the urine and the filtration stalls. Why? Sepsis is the trigger here, because that's really the major insult. Well, sepsis is causing what? global vasodilation, capillary leak, microvascular ischemia. These kidneys are simultaneously underperfused and exposed to inflammatory toxins. So what do you do in this case? How do you think about it? Well, if the fraction of excreted sodium is greater than 2%, the urine is dilute, muddy casts are present, you can confidently localize this injury to the tubules. So the next step isn't fluids, it's supportive management. Okay, let's talk about the management then. So, what is the first thing you're going to do when we say supportive management? Well, number one, stop the nephrotoxic drugs, aminoglycosides, NSAIDs. Stop it. Maintain adequate perfusion pressure with vasopressors if needed. You want to monitor potassium, it was 5.8, and the acid-base status very closely. You want to adjust all medications that are needed for reduced GFR. So in this patient is when you would start to renally dose the medications. Now, what you want to pay attention to here is acute tubular necrosis does not resolve in a matter of hours. It takes time. There are 3 phases you'll see, and you'll know you're on the right path of resolving this acute tubular necrosis. Number 1 is the oliguric phase. This is urine output drops and potassium rises. Okay. The 3rd phase is the diuretic phase. As the cells regenerate in the kidney, right, urine output will increase, but the kidney can't yet reabsorb the solute. So you still won't see that change in sodium. And then the recovery stage is when you normalize the tubular function. Acute tubular necrosis is an intrinsic acute kidney injury caused by ischemia or toxic injury to the renal tubule, marked by a fraction of excreted sodium of greater than 2%, isothenonuria, and muddy brown casts. Okay, that's when the plasma and the urine osmolality are the same because it's not diuresing or filtering. Always remember that if the kidney stops responding to volume and the urine turns muddy, you've crossed over from reversible perfusion problem to a true structural injury that may not totally come back and may progress if you don't fix it. Okay, now the most common factor that we deal with, at least if you work in surgery, this is the most common. If you work in urology, also fairly common. So we've covered prerenal and intrinsic causes. Now let's finish this trilogy with acute kidney injury, the obstruction story. So here, the kidneys are structurally intact and perfused, but urine cannot exit. So the result is pressure backup and rising tubular pressure that compresses the glomeruli and then reduces the glomerulofiltration rate, which is then why you see the creatinine start to creep up. Think of this like the heart is still pumping, the kidneys are still filtering, but the drain is clogged. Now, what's the villain here? There are 4 culprits to keep in mind, maybe 5. I'm going to lump one of these 2 together. So in men, benign prostatic hyperplasia. This is the most common cause of postrenal failure. And over the week, I discovered in a patient that also phimosis can cause postrenal obstruction. He had such a tight constriction that he's not able to pass urine out. He also had BPH, horrible BPH, to the point where his bladder had become cone-shaped. And so they were intermittently straight cathing. And then, of course, what happened? That irritated the urethra and gave him what? A urethral stricture. So the poor man has no hope in sight. Of course, he's an AFib, and of course, he's on an anticoagulant, and of course, he's a falls risk and has Parkinson's and early vascular dementia and already fell and developed a subdural and went from the assisted living into the hospital and shows up, and the disciplines are not talking to each other. And then the nurse has to come, of course, and read the chart and say, well, why won't they work on this thing? Like, just put a catheter in and stop with this in and out. Sure enough, he got a catheter eventually. Here he's back in the ALF now. Another thing that can obstruct is urolithiasis. Urolithiasis, kidney stones. What's phimosis? Thymosis is when the foreskin is very tight around the glands of the penis, typically in uncircumcised men only, and the definitive treatment is circumcision. As an adult, much more painful, much more problematic, especially if they're on an anticoagulant in atrial fibrillation with an active UTI and a bad prostate. See, that risk factor just kind of went up through the roof there. Urolithiasis, kidney stones. So this is especially the case if it's bilateral or obstructing a single functioning kidney. So like if they have one kidney with dysfunction and it's dead, say, and then the other one gets a stone, that's how you can get a postrenal obstruction. Another factor, of course, is malignancy, be it prostate, cervical, bladder. All of these things can compress or invade whichever outflow tract, and that can give you postrenal failure. And of course, neurogenic bladder. So failure to empty due to neurological dysfunction, be it diabetes, spinal cord injury, medications that you may be on causing hesitancy and retention, things like that. Those can all be triggers. So in the psych population, all the anticholinergics, the tricyclics, all of those can cause it. Even the antihistamines, diphenhydramine, all of that can cause hesitancy and outlet obstruction. The clue here is that the postrenal acute kidney injury is often reversible if it's caught early. And your tell is you're looking for fluctuating urine outputs, suprapubic fullness, or new leaking incontinence. If only one kidney is obstructed, the serum creatinine may actually stay normal for a long time because the kidneys are remarkably adaptable. So it may stay near normal and you may completely miss it. But you have to catch it eventually in order to treat it. So what's the diagnostic approach here? Well, the whole take-home message here is going to be in visualization. So the best thing is obviously going to be a renal ultrasound. And what you're looking to see is you're going to see something called hydronephrosis. What that is basically the fluid is backing up and causing a dilation of the renal pelvis and calyces caused by this backup fluid pressure. The ultrasound rules out postrenal obstruction before labeling the acute kidney injury as intrinsic. So now you know why we're doing a renal ultrasound. And you can also do a post-void residual, which is a very simple bedside renal ultrasound to clue you in. But what you're concerned with depends on where the blockage is identified. If you have a bladder outlet, then maybe you put a Foley catheter and trial with bladder scanning. If you're ureteral, then maybe urology consult, maybe they need a nephrostomy tube. If it's prostatic or malignant or compressive, then you have to undress the underlying mass or BPH, be it medically or surgically. So post-renal acute kidney injury, PAKI, is a plumbing problem. Its urine flow is backed up, the pressure rises, the filtration falls, the fix is mechanical, not medical. If the urine stops flowing, don't reflexively order fluids. Make sure there's somewhere for the urine to flow. So go check the Foley, make sure it's not kinked if you're doing inpatient work. Okay. So here's a case for post-renal acute kidney injury. Consider this 72-year-old man with a known benign prostatic hypertrophy who presents with suprapubic fullness and a rising serum creatinine from 1.5 to 4. So the first thing you need to do is recognize the problem, right? Post-renal obstruction. The kidneys are functioning, but the urine can't escape. So the ultrasound will seal the diagnosis, bilateral hydronephrosis, meaning that both renal pelvises are distended from back pressure. Unusual to have bilateral hydronephrosis, so that's kind of how you've been able to distinguish this. The story here is simple but critical. So the villain in this situation is the mechanical obstruction, not the poor perfusion, not tubular damage yet. So the bladder outlet is blocked by an enlarged prostate. The pressure backs up into the ureters, the kidneys, and that raises the tubular pressure, collapsing the filtration process. And at this point, giving fluids and diuretics are not going to help. So you can't fill a system that's already clogged. That's the problem here. So post-renal acute kidney injury management. The correct action here obviously is the bladder decompression, something as simple as a Foley catheter immediately. If you're uncertain whether the obstruction is distal or higher up, start with a bladder scan. If the volume is greater than 300 to 400, then that's your answer right there. Okay. After insertion, then you monitor closely for post-obstructive diuresis. That's a period of high urine output as the kidneys clear retained solutes and water. You want to be sure that you replace those fluids judiciously to prevent hypovolemia. That's why you may have heard in the old days of nursing school that if you put out a liter of fluid, clamp the Foley tube, and then let it go again in a half hour. That's what you're trying to prevent here. If the Foley placement fails and there's no improvement, so this is when you're going to consult urology, they may need a suprapubic or they might need ureteral stenting or further evaluation. Once the obstruction is relieved, the creatinine will often get better in 24 to 48 hours. So that confirms to you how reversible this is. If the kidneys stop working, check the plumbing first. It's the most easily missed but most fixable problem of acute kidney injury. Bladder scan, Foley placement can save the kidneys within minutes. So it's the simplest intervention and often the most life-changing because they're often in a lot of pain when they're in this much retention. Well, because we're not dealing with the issue here. Think about this though. You may get hypotension. So if you have this big balloon filled up in your abdomen, if you let out all this volume, it's not unreasonable for them to get orthostatic. That's going to be a personal preference. I would rather not deal with it. It's easy to let it out in 1,000-liter increments, in 1 liter increments. You do you. All right. So here is the algorithm to deal with acute kidney injury. Step one, review the serum creatinine trend and urine output to confirm acute decline in function. Ensure the rise in creatinine meets the diagnostic criteria, and it's not just due to lab variability or chronic baseline, that KDIGO guidelines. Step two is you want to assess for hemodynamics and perfusion. So evaluate volume status, blood pressure, orthostatics, mucous membrane, skin turgor, JVP, all those assessment things to help support your diagnostic process. If they're hypovolemic or hypotensive, well, then initiate cautious fluid resuscitation, isotonic solution like saline, and then reassess the renal function as this goes on. Once you've done that and there's no improvement after adequate volume repletion, then you go to step three where you're trying to localize the cause. Is this prerenal, intrinsic, postrenal? And the way you're going to do that is you're going to look at the fraction of excreted sodium. Less than 1, high BUN to creatinine ratio of greater than 20 to 1, concentrated urine of 500 milliosmoles per kilo, that's prerenal. Intrinsic, the fraction of excreted sodium is greater than 2%, muddy brown or red blood cells or white blood cell casts. That is your intrinsic diagnosis. Postrenal, fluctuating urine output, anuria with bladder distension or hydronephrosis on the ultrasound. There's your postrenal. Always you want to consider and discontinue any offending potential nephrotoxins, NSAIDs, ACE inhibitors, ARBs, aminoglycosides, IV contrast, etc., antibiotics, proton pump inhibitors, chemotherapeutic agents, etc. Imaging. The renal ultrasound early in the workup is done to exclude obstruction early on. You want to take that out of the differentials and reduce the variables quickly. And then you manage according to etiology, obviously. So prerenal, you restore the perfusion, optimize the fluids and cardiac output. Intrinsic, you remove the offending agents, maintain euvolemia, check the electrolytes, consider a nephrology consult. Postrenal, you want to relieve the obstruction, Foley catheter, stent, surgery, etc. And then ongoing monitoring with what? Daily weights, fluid balance, electrolytes, serum creatinine, and adjust all medications to the current GFR. It may change as they improve, so then you can up the dose if you want to, but by that time you've involved nephrology. This algorithm will help you make sure that you are very systematic in your approach to acute kidney injury, and so that you can confirm the diagnosis and prevent the progression. All right. Why don't we take a 5-minute break now, and then we'll do chronic kidney disease. I think shorter breaks more often are more useful here. All right, welcome back. So now we're going to talk about chronic kidney disease. So by definition, chronic kidney disease means there's an abnormal kidney structure or function for at least 3 months or more. And that's defined as a GFR of less than 60. So that is the definition of chronic kidney disease, regardless of cause. So the common final pathway in the nephron loss leading to hyperfiltration of remaining nephrons. This is the final stage. Over time, this compensatory hyperfiltration causes the glomerular sclerosis and progressive decline in function. That's what gives us this condition. But because this condition takes time to develop, that's why this criteria is listed for 3 months or longer. So what are some common things? Well, if you think about how frequently you encounter this CKD diagnosis and what comorbidities these patients have, it starts to make better sense. So for example, the leading cause of CKD is diabetes. Diabetic nephropathy is the leading cause of CKD. Obviously, hypertension, second most common cause. Hypertensive nephrosclerosis can develop, and oftentimes you'll have diabetes and hypertension together. Polycystic kidney disease and other hereditary disorders are bringing up the rear in terms of things that cause chronic kidney disease. You can also have these conditions develop from something like chronic toxin exposure, like low-level toxins over time, like these people that pop NSAIDs every single day because it just helps me. But over time, it's going to take a toll, especially if there's any sort of predisposition with polycystic kidney disease along the way. So CKD is usually asymptomatic in the early stages, and it's often discovered through routine labs showing an elevated creatinine or an abnormal urine analysis. It's like, when did this happen? Can I see your past records? Can we see past labs? And that's how you can quantify this thing. Otherwise, you're going to bring them back for monitoring. And maybe if you see the kidney failure persist and getting worse in your presence, then they're going to warrant a referral at that point. CKD is classified according to 5 stages based on the GFR and albuminuria. So it's a G1 through G5, A1 through A3. And you don't need to learn how to classify it, but just suffice it to say, if you're in nephrology, there is a separate classification system for chronic kidney disease. Now, what you want to do is identify and control any underlying causes like the diabetes and the hypertension. And your aim is to basically manage the decline, slow the progression by managing things like blood pressure and proteinuria. Normally, you'll give things like ACE inhibitors or ARBs to manage the proteinuria. Obviously, you want to monitor electrolytes, and this is where you're going to take a more comprehensive approach, and you're going to monitor bone mineral metabolism and anemia. Because remember, the kidney's function is also regulating those processes as well. So when you think chronic kidney disease, you're going to start thinking about anemia and metabolic bone disorders. The key contrast from acute kidney injury is that chronic kidney disease is irreversible, but it is modifiable. So the goal is to preserve the remaining function. You want to prevent complications, and unfortunately, you're going to have to want to prepare them for renal replacement if the decline continues. And renal replacement, I mean dialysis or transplant. So what's the pathophysiology of chronic kidney disease? This involves progressive nephron loss from an initial insult. That initial insult could have been metabolic, vascular, or immune mediated, followed by usually a maladaptive compensation by the surviving nephrons. Because remember, it's all trying to restore normal function. So like nephron injury and loss, primary injuries can result from things like hyperglycemia, hypertension, inflammation, toxins, ischemia. Damaged nephrons become sclerotic and then drop out of circulation. That reduces the overall filtration surface area because you don't have all the nephrons firing on all cylinders. Secondly, glomerular hyperfiltration. This is when the remaining nephrons increase single nephron GFR to maintain overall function and filtration. This is an adaptive response. It raises the intraglomerular pressure, leading to capillary wall stress. and eventually endothelial injury, and eventually progressive glomerulosclerosis. So you can see this progression over time. Thirdly, tubulointerstitial fibrosis. This is chronic hypoxia and cytokine release in the setting of this chronic hypoxia. And then what you develop is oxidative stress that promotes fibroblastic activation. This results in collagen deposition, tubular atrophy, and interstitial scarring. Finally, there's these systemic consequences that then will ensue. As the functioning nephrons decline, the kidney loses ability in order to regulate volume, electrolytes, acid-base balance. So what you will see, phosphate retention, right, high phosphate levels, leads to secondary hyperparathyroidism and the bone disease. So that's the connection as to why we're thinking bone. Erythropoietin will be deficient eventually. That's what's resulting in the anemia. Uremic toxin accumulation, that's what contributes to the chronic fatigue and the cognitive changes, and maybe even the pericarditis in the advanced stages. So those are the reasons that chronic kidney disease start to cause those downstream effects. Now, this model will progress regardless of the original cause. Once this cycle of hyperfiltration and fibrosis begins, progression becomes this self-perpetuating phenomena. Early recognition and intervention, obviously, especially things like blood pressure control and reduction of proteinuria, are the two most high yield interventions that you can use to slow this decline. Chronic kidney disease progression is driven by this combination of hemodynamic stress, inflammation, and fibrosis that ultimately will reduce nephron numbers and function over time. So some complications can occur. So chronic kidney disease tends to affect every major organ system through the retention of metabolic waste and the loss of the hormonal regulatory functions. So first, cardiovascular disease. It's the leading cause of death in chronic kidney disease patients. And the driver behind that is what you might guess: hypertension, volume overload, anemia, vascular calcification, accelerated atherosclerosis, eventually left ventricular hypertrophy occur due to what? Chronic afterload and anemia. So remember last time I gave you the 4 levers in cardiology that you're pulling on: preload, afterload, vascular resistance, and heart rate. So the other major way this gets deranged is electrolyte and acid-base disturbance. The primary electrolyte disturbance that we have to worry about is hyperkalemia from impaired potassium excretion. The other major factor as this progresses is metabolic acidosis from reduced acid secretion and bicarbonate reabsorption. So my lady with the creatinine of 3, she's having reduced acid secretion and increased bicarb reabsorption. She's not able to buffer herself, so she really would benefit from sodium bicarb with her hyperkalemia of 5.8. Another electrolyte derangement is hyponatremia or even hypernatremia, and what that's due to is the disordered water handling. So you might have one or the other, and so you have to think down, what does this really mean? The mineral and bone disorders, CKD, MBD, this is due to the phosphate retention and low calcitrol levels. This is what leads to that secondary hyperparathyroidism. This results in things like bone pain, osteitis fibrosa, vascular soft tissue calcification. So these are some metabolic bone disorders that can develop. Anemia of chronic disease is another major thing we need to think about. That's due to the decreased production of erythropoietin and reduced the lifespan of the red blood cell. And that too can further contribute to fatigue, dyspnea, and worsened cardiac workload. Another major factor, as you may have guessed, is the fluid volume overload from impaired sodium and water excretion, leading to things like edema, pulmonary congestion, and hypertension. Uremic syndrome, that can develop as well. That's because all the toxin accumulation due to things like nephropathy, pericarditis, platelet dysfunction, neuropathy eventually because of the pain associated with the inflammation and uric acid overload, and also eventually cognitive impairment. Endocrine and metabolic effects can also develop due to chronic kidney disease. So you may see things like insulin resistance and altered lipid metabolism. In and of themselves, those two things raise the cardiovascular risk profile of the individual. And also reproductive hormone imbalances, which can cause menstrual irregularities and decreased fertility. So, what is your main priority given all of these complications that can develop here? Well, same thing applies. Airway, breathing, circulation, right? Control the blood pressure and the volume, manage the potassium, phosphate, and acidosis, treat the anemia with erythropoiesis stimulating agents, iron supplementation, initiate early nephrology referral when the GFR is less than 30. They need to get in there because that's when more complications will emerge. The key point is that most CKD is systemic and interrelated. So you have to address it as one phenomena, like phosphate or anemia. Often improves the overall stability and reduces the further decline. You kind of have to address the whole picture. And everything is very meaningful in this population. Okay. So here's a case of CKD in this 58-year-old woman. And so what we need to look at is her longstanding diabetes. She's grade stage 3B. Look at her GFR, right? It's below 60 and for more than 3 months. So that confirms her diagnosis. Her level of the albuminuria, A1 through A3, that further will help classify the risk here. And it's persistent albuminuria, 30 milligrams per gram, and it increases both progression and cardiovascular risk. So we have to determine here what is the underlying cause. Most commonly, we said diabetes, hypertension. So first thing we want to do is review the medication list for nephrotoxins. Are there NSAIDs, ACE inhibitors in the wrong setting? Has she had contrast exposure? Is she taking lithium with any degree of chronicity? The other thing you want to look for is any structural causes like obstructive uropathy or any inflammatory causes like what? Lupus nephritis. Finally, you want to look for complications like what? Electrolyte derangement, hyperkalemia, metabolic acidosis, volume status, fluid overload, or hypertension, hematology problems like anemia due to erythropoietin deficiency, and mineral metabolism like elevated phosphate, low calcium, secondary hyperparathyroidism. Now, how do we manage this? Well, step one is always control the blood pressure with ACE inhibitors or ARBs unless contraindicated. Okay. You always want to optimize glycemic control if they're diabetic. You want to limit sodium and protein intake and avoid nephrotoxic agents. You want to monitor potassium, bicarb, phosphate, calcium, and hemoglobin regularly. So this is your CMP at calcimagphos to your CMP and your H&H. And then, of course, you check the reticulocyte count at 1 point. Why? Because what? Reticulocyte tells you, are we making red blood cells? Remember? Good. And then you refer to nephrology if the GFR is less than 30, rapid decline, resistant hypertension, or an unclear etiology. That's how you know who to refer to nephrology. And what you want to tell the patient is reinforce that this is a chronic and progressive nature of CKD, emphasize medication adherence, diet, regular follow-up, discuss the importance of vaccines as well because they become immunocompromised, especially Hep B, before advanced CKD develops. The overall goal in CKD is what? Slow progression, prevent complications, maintain quality of life, and get nephrology on board because if this goes south bad enough, you're going to eventually wind up in the dialysis and transplant category. You're using the ACE and ARBs to prevent proteinuria, but if there becomes a circulation problem or they're hyperkalemic, at that point you can't do it because the ACE and ARBs will further raise the potassium. So that's why ACE inhibitors, unless contraindicated, and that would be with the severe hyperkalemia. So now we have acute on chronic. So we did acute, and now we're doing chronic, and now we get acute on chronic. So acute on chronic kidney disease is often abbreviated AOCKD, acute on chronic kidney disease. And this means that an acute insult has landed on top of a pre-existing chronic impairment. Catchy, huh? Catchy name, these people. By itself, chronic kidney disease is a slow decline in renal function, while acute kidney injury is abrupt. But when the two come together, this chronic disease provides a fragile baseline. So even small acute changes can cause dramatic shifts in laboratory findings. Patients with chronic kidney disease already have reduced nephron reserve, so their kidneys operate close to the edge with limited ability to buffer new stressors. So as a result, minor insults like a brief episode of dehydration, sepsis, or exposure to a nephrotoxic drug can cause this disproportionate rise in the serum creatinine. Obstruction, such as BPH or stones, is another frequent but reversible cause which can trigger this acute on chronic flare. So what you want to do is look for a patient with a known baseline creatinine that is chronically elevated, now showing a sudden upward spike. They may present with oliguria, rising potassium, metabolic acidosis, uremic symptoms such as nausea, confusion, pericarditis. This distinction is important to recognize because the acute component offers a chance for reversal, even if the chronic background stuff remains the same. Recovery is going to be less complete than the straightforward acute kidney injury because that chronic disease limits the nephron regeneration. So each acute hit accelerates this march towards end-stage kidney disease, making this prevention and early recognition vital. The thing to remember here is that acute on chronic, you are treating both timelines. You're rescuing the patient here from the acute threat while also managing the chronic disease to slow long-term decline. So what's the pathology here? Well, patients with chronic kidney disease already have nephron reserve reduction, and their kidneys operate close to the edge with limited ability to buffer new stressors, right? So as a result, minor insults can cause this flare-up. So you're looking for a patient with known baseline creatinine, and then it elevates above that. The recovery can be complete, but it's going to be less complete than the pure acute kidney injury presentation. So take a look here at this case of a 65-year-old with CKD4 given IV gentamicin for pneumonia. Okay. So what is the current labs? 5.1 creatinine, up 82% from baseline. The potassium is 6.2. You have muddy brown cast and a FeNa of 2.5%. So this is a nephrotoxic acute tubular necrosis superimposed on chronic kidney disease, right? So the last known creatinine, so the recent albumin to creatinine ratio, any prior episode of acute kidney injury, knowing the baseline is the thing that will distinguish this for you. So what changed here? Well, he had a nephrotoxic agent. And so that's the new insult. So NSAIDs are recent IV contrast, aminoglycosides and the like. And the danger now for this person is what? It's the potassium, it's the hyperkalemia, this metabolic acidosis, and his volume status is a major factor. So what do you do for this person? Step one, cardiorespiratory check, EKG, right? If hyperkalemia is suspected, you always want to treat dangerous potassium first. So you give things like calcium gluconate for membrane stabilization. This person gets insulin and dextrose, maybe a beta agonist nebulizer, maybe a potassium binder, maybe some loop diuretic, but you have to be careful because the creatinine's already elevated if volume allows. And then you want to check their volume status here. If they're dry, cautious saline, because overloaded diuretics and afterload reduction can become a factor as well. You don't want to cause heart failure and then hypoperfuse further. So that's a problem. Obviously, hold the gentamicin because it's nephrotoxic, and review all meds for renal dosing, including the DOACs, which is the direct acting anticoagulants that they may be on. And then also a point of care ultrasound here, because you want to assess renal perfusion and make sure we're not missing any obstructive factors. Urine analysis in this person, this is the one that's going to show you muddy brown granular casts, white blood cells, the eosinophils if it's acute interstitial necrosis. Remember, red blood cell casts for glomerular nephrosis. And so that's what we're looking at. So acute kidney injury on chronic kidney disease patients have less reserve and require this early intervention. You can do that. You can give localma for getting the potassium down in this case. Yeah. So how do we manage this? Well, we want to stabilize the threats, treat the underlying hyperkalemia. You want to stop the offending agents. You want to keep the condition from progressing, correct anything that's reversible, offer supportive measures, and then you want to consider, are we heading down the path of do they need temporary dialysis, right? And how do you know if they need temporary dialysis? Well, AEIOU. What? AEIOU, this is when you would start dialysis. What are you talking about? My vowels? Yes, your vowels are a mnemonic and they stand for acidosis, right? If metabolic acidosis persists despite bicarb therapy and is impairing hemodynamics or ventilation, they get dialysis. If your electrolytes, hyperkalemia is the classic trigger. If calcium, insulin dextrose, beta agonist binders fail or the ECG change appears, you get dialysis. If you have ingestion, some toxins that are dialyzable because they're small, water soluble, and have low protein binding, like what? Lithium, toxic alcohol, salicylates. When those are present or strongly suspected, you get dialysis. Overload. If you have pulmonary edema, severe volume overload, not responding to high dose loop diuretics with or without thiazide synergy, requires ultrafiltration, you're going to get dialysis. What about uremia? Well, if you're clinically uremic, encephalopathic, have pericarditis, a friction rub chest pain, intractable nausea, vomiting, bleeding from platelet dysfunction, you get dialysis. So the point of the matter is acidosis, electrolyte ingestion, overload, uremia, AEIOU, those are the indicators for dialysis. Now, you need to choose the modality, intermittent hemodialysis versus continuous therapies, like if they're hemodynamically unstable, based on blood pressure and ICU status. You need to have good blood pressure to withstand hemodialysis. If you don't have that, then that's going to become the CRRT person that you're playing with. So don't delay for a perfect workup, by the way. If you meet any one of these AEIU criteria, any one is enough. Dialysis can be both diagnostic and therapeutic in this case. And just because you get it once, it doesn't mean you have to stay on it. You can do bridge dialysis, short-term dialysis, buy yourself some time, and then you reassess daily. Some patients only need a very short bridge while the kidneys recover from the acute injury. But this is the criteria for dialysis. All right, so let's take a look at this 50-year-old man, right? He presents with swelling, high blood pressure, and foamy urine. His labs show heavy proteinuria, greater than 3.5 grams a day, right? Low serum albumin, hyperlipidemia. This is the classic tetrad of nephrotic syndrome. So let's break it down. Proteinuria of greater than 3.5 grams a day. The glomerular filtration barrier here is severely damaged. Hypoalbuminemia, loss of albumin in urine reduces plasma oncotic pressure, causing edema. Edema, this means fluid has shifted into the interstitial space, often seen in legs, periorbital area, or ascites. Hyperlipidemia, the liver ramps up the lipoprotein synthesis in response to protein loss. So what happens? That raises the cholesterol and the triglycerides because what's going on is the body is trying to compensate. I want protein in the vessel to pull fluid in because I want fluid to perfuse the kidney. But what's happening is it's leaking all over creation and the triglycerides are going up and we can have a picture that mimics ascites. Hypertension, both sodium retention and the RAS activation contribute. And the most common cause at this age, including diabetic nephropathy and membranous nephropathy and focal segmental glomerulosclerosis. All of these things can be going on. And the specific diagnosis for which problem you're dealing with is always going to be for biopsy. So what's the goal here? The goal here is going to be to reduce the proteinuria, right? And the intraglomerular pressure. So to do that, we use ACE inhibitors or ARBs. The ACE inhibitors or ARBs are used to enhance the renal perfusion and reduce the proteinuria. The other thing you want to do here is manage the edema. So we do things like sodium restriction and some diuretics. You have to address the hyperlipidemia in this case with statin therapy. And also you want to prevent further complications of nephrotic syndrome because this can increase the risk of infection and the loss of immunoglobulins. And thrombosis can start to form because we start to lose antithrombin 3. So anticoagulation may also be a factor in this high-risk patient here. So the main goal with this is you want to always identify and treat any underlying condition, or at least reduce it. Diabetes, autoimmune, malignancy, etc. Nephrotic syndrome is not just protein in the urine. It's a systemic disorder that affects fluid balance, cardiovascular risk, infection risk, clotting. So recognizing this full syndrome ensures that you're treating just beyond the creatinine. So dialysis management. So what we do here is realize this is life-sustaining, not curative. This just removes toxins, corrects electrolytes, and balances the fluids when the kidney cannot. But it never replaces, unfortunately, the endocrine function. So these people will need erythropoietin supplementation and vitamin D. So you may choose a number of modalities. Intermittent hemodialysis, this is IHD. That's the standard in the stable patient. That's the one that goes 3 times a week. They meet the AEIOU indicators there. Another option is continuous renal replacement therapy, typically used in ICU patients with hemodynamic instability. It removes fluids and solutes very gradually. It runs 24/7. That's how gradual this thing is. It's a bear to work with. If you're an ICU nurse and you see CVVHD set up in your patient's room, you're going to be very busy because every hour you're emptying bags and filling bags and balancing the scale. And you're doing labs very frequently. So those MICU nurses and those CTICU nurses, God bless them. The other thing we have is peritoneal dialysis. This is an outpatient option, gives you a lot of freedom, a lot of autonomy. It uses your peritoneal membrane for solute exchange. So this is so common that if you go to the first aid station at the Magic Kingdom Disney World, they have a dialysis room. That's how common this is, apparently, where people come from all over and they're doing peritoneal dialysis and they can still enjoy the Magic Kingdom. So you never want to wait for creatinine or a BUN threshold to start dialysis. That's not the trigger. The trigger is the clinical decompensation, summarized by the AEIOU, acidosis, electrolytes, ingestions, overload, uremia. Surround each dialysis session with a lot of supportive care. Adjust the medications for renal clearance, manage volume before and after, watch the electrolytes closely, and learn to anticipate complications. Like if you've worked in dialysis, hypotension's a big one, pulmonary edema is a big one, vascular access infection, clotting off the line, stenosis, fistulas, disequilibrium syndrome, rapid shifting. Dialysis is a beast unto itself, but keep in mind, we're bridging. It's not an endpoint. We're just buying time to hopefully the kidney recovers or transplant. All right, so now I want to talk about the urine labs interpretation. We order a lot of these things. They're broad categories. We have serum markers and urine studies and some specialized tests. Let's talk about what all these things mean here. So the urine analysis and microscopy, this is one of the highest yield tests in nephrology because it localizes the disease to a part of the nephron. Think of this like the liquid biopsy, okay? So first you get the dipstick analysis, and on the dipstick you can see things like protein, detects not what kind, usually it's albumin, but not necessarily. It will also detect blood. So a positive dipstick could mean RBCs, hemoglobin, myoglobin, microscopic will sort out what it is you're actually seeing. It also will tell you glucose. This appears when plasma glucose exceeds 180 milligrams per deciliter, or when the tubular reabsorption is impaired for some reason. You can also see things like leukocyte esterases and nitrates. That suggests a urinary tract infection. Nitrites indicate that it's a gram-negative bacteria that reduces the nitrite. Also, you'll read specific gravity, and specific gravity reflects the urine concentrating ability. So low specific gravity can signal tubular dysfunction. Low, dilute, high is concentrated. Low specific gravity, the urine is diluted. High specific gravity, it's concentrated. Okay. So let's talk about the different urinary casts and indices. So the red blood cell casts, these are diagnostic of glomerulonephritis. Red blood cells molded into casts in the nephron confirm that bleeding is intrarenal, not from the bladder or the urethra. You only can tell that on the microscopy. You might see dysmorphic red blood cells. These are misshapen cells from the glomerular basement membrane damage. That reinforces a glomerular source for the hematuria. Again, only visual on the microscopy. The white blood cell cast seen in acute interstitial nephritis or pyelonephritis. These prove that you have inflammation. So whenever you have white cells rushing to a source, something is going on. That inflammatory cascade has begun. So you're looking for infection within the kidney itself. If you have muddy brown granular casts, this is classic for acute tubular necrosis. That means dead tubular cells have sloughed off into the urine. And if you have hyaline casts, this is often benign. It can be seen in dehydration or something called prerenal azotemia. Azotemia just means you have a high creatinine and high BUN. It's a lab finding. Uremia is azotemia with symptoms. So just because you have a BUN and creatinine that's high, you're azotemic. You're not considered uremic until you have symptoms, fatigue, encephalopathy, etc. Okay, that's the distinction there. So another thing you might see are crystals in the microscopy. Uric acid generally gets you to think of things like gout or tumor lysis. If you see calcium oxalate, that's ethylene glycol ingestion. I wrote an article about this. You could pull it up. It's called Resolution of a Cranial Nerve Deficit in Glycol Intoxication. We had a man who drank antifreeze trying to kill himself, and it's sweet, so he just drank it. And what happened was the damage happens in antifreeze toxicity because calcium oxalate crystals will deposit in the kidneys, and that causes the renal failure, and it happens so gradually that they often will die before they're caught. Suffice it to say, he was caught and found. It deposited oxalate crystals along his cranial nerves and caused a facial droop. And I thought, oh, that's kind of interesting. So I wrote that up in a case study. You can search it out and have a great day. Struvite is another thing you can find in the urine. Struvite is typically indicative of infection stones. Urease producing bacteria will cause struvite stones to form. And finally, cysteine is another crystal or stone that can be in the urine. Cysteinuria, rare inherited condition. But all of this shows up in microscopy if you look. They won't report it unless they see it. The teaching thing here is that when you're unsure whether this is acute kidney injury, is prerenal, intrinsic, or postrenal, carefully look at the urine sediment, and that will tell you more than any expensive scan. Muddy brown casts, acute tubular necrosis. Red blood cell cast, That's glomerulonephritis. White blood cell cast, interstitial nephritis, or pyelonephritis. So that's like the stethoscope of nephrology. Okay. And then, of course, we look at these indices here. The fraction of excreted sodium, less than 1. What's the kidney doing? Conserving sodium, prerenal. 2, the kidney is wasting sodium, intrinsic, tubular injury. The formula is there. That was on previous slide. And we have urea here? No, but that's fine. And then the urine osmolality is the other thing to pay attention to, which is the 500 osms. That's concentrated urine, consistent with prerenal. So the cast will give you the morphological evidence, and the index will tell you the functional physiology. Okay, so the cast will say, where is it coming from? And the index will say, to what degree is it affecting things? And when interpreted side by side, this is quickly helping you sort prerenal, intrinsic, postrenal without delay, without invasive testing. Just simple lab tests, pretty cheap, pretty accessible. No lecture would be complete until we covered UPEP and SPEP. Now, I'm not going to turn you into oncologists. This is typically done when we're looking for multiple myeloma. It's essential because this is often a first step test you might do prior to referral so that when they get to the referral source, this can be acted on. This is essential for evaluating plasma cell disorders that will damage the kidneys. So serum protein electrophoresis is describing serum proteins that are separated into bands. And those bands are albumin, alpha 1, alpha 2, beta, and gamma globulins. Now, all of this will be written up on the sheet. If you just order serum protein electrophoresis, this will all appear on the sheet. In multiple myeloma, which is the thing we're looking for when we do this, or related disorders, we're looking for a single clone of plasma cells producing large amounts of immunoglobulin. So the SPEP in this will appear with something called a sharp monoclonal spike, called an M spike. That's what you will see on the test. If you see that, that's indicative of we're heading towards a multiple myeloma picture, usually in the gamma region. A polyclonal increase in the gamma region, by contrast, will reflect generalized immune activation. So when you see that, you're going to think, okay, infection or autoimmune disease. That's more reassuring because, may be treatable and reversible. Serum protein electrophoresis is used as a screening tool for a host of conditions, including multiple myeloma, monoclonal gammopathy of undetermined significance. That's what they call MUGUS, MGUS. Other things can be something like amyloidosis, macroalbuminuria, and things like that. So typically your referral is going to either be to hematology or rheumatology, depending on what the abnormal finding is here. And the lab slip will tell you what the findings indicate. The other thing is urine protein electrophoresis. This test is a complement to serum protein. They're done in conjunction by looking for light chains, kappa or lambda, and these split into urine. That the kappa and lambda light chains are spilled into the urine, and they're known as the Bence-Jones proteins. So these are light chains that are freely filtered at the glomerulus and can cause cast nephropathy. This is a common renal complication of multiple myeloma. Urine protein electrophoresis helps confirm the monoclonal protein excretion and quantifies to what degree. The tests are done together. Now, some patients produce mainly intact immunoglobulins, which are detectable on the SPEP. Others produce primarily light chains, and they only show up on the UPEP or with serum-free light chain assay. So using SPEP and UPEP and the serum-free light chain assay together, this maximizes the sensitivity for detecting the problem. Where this gets done, if you have the elevated proteinuria and the high creatinine, and you've done the imaging, and you've done the UA with microscopy, and you're about to refer them to nephrology, you may do the UPEP, SPEP on the way out the door, so when they arrive, they can see it. The thing is, this is typically repeated also. So when they get there, they can have at least a trend. Trends are much more meaningful in clinical practice than isolated values. So when you have unexplained renal dysfunction and it's accompanied by proteinuria that's not albumin predominant, or it shows low albumin to protein ratio, you always have to think about monoclonal proteins, and it's the SPEP and the UPEP, which is the frontline tool for screening for these conditions. So this is basically what is your next step if the patient is not responding or giving you the results you're looking for. This helps you move the ball further down the field. Okay, so take a look at this case here. We have a patient with a cola-colored urine, edema, hypertension after a urine upper respiratory tract infection. So I'm describing something very specific here. They had a viral infection. It's now pointing towards something like nephritic syndrome, an inflammatory glomerular process that classically causes hematuria, modest proteinuria, and reduced GFR. So the urine analysis here is what anchors this diagnosis for you. The red blood cell cast means that bleeding is intrarenal, formed in the tubules. They virtually localize the pathology here to the glomerulus. The protein is only +1. It's lower, right? So that fits the nephritic picture. Inflammation dominant, rather than the nephrotic picture where I said in the beginning, high proteins, right? This is lower proteins. Now, the thing about this is this intrinsic glomerular disease situation. The fraction of excreted sodium is what? 2%. These tubules are not avidly reabsorbing sodium. This supports further that this is intrinsic renal versus prerenal, because then it would be less than 1%. The other thing here is this complement value, this low C3 complement. This is a classic post-infection finding in glomerulonephritis, especially post-streptococcal glomerulonephritis. Complements usually recover to normal within weeks. So what's going on here? We have a streptococcal infection, often group A beta hemolytic strep, has triggered an immune complex deposition into the glomeruli, activating the complement cascade. The resultant glomerular inflammation injures the filtration barrier. So the red blood cell is leaking hematuria and red blood cell casts. Some albumin is leaking, that's your +1 proteinuria. The GFR falls, there's fluid retention, edema, and hypertension as a sequelae. And so what you're looking for here is diffuse endocapillary proliferative glomerulonephritis. That's what the biopsy would show on your path report, okay? Because you're going to eventually need a pathology to tell you what this situation is. So what is the typical timeline? When do you have to worry about this? So this is the patient that says within 1 to 3 weeks after a strep pharyngitis, a little longer if they have something like impetigo, but consider checking an ASO titer and an anti-DNase B titer to support the recent streptococcal infection. So you come in 3 weeks after the fact, complement is low, trending back to normal in about 6 to 8 weeks is reassuring for this post-infectious glomerulonephritis. The management here is treat the inflammation consequences, supportive care, sodium and water restriction, loop diuretics for edema, antihypertensives, often calcium channel blockers to control the blood pressure. And of course, you want to make sure that the strep is eradicated. So this is going to definitely, and then you're going to obviously weigh the dialysis criteria. But if they're this acute, this is who you're going to wind up referring into nephrology. And along the way, avoid the NSAIDs for pains and aches and fevers, nephrology consult here. But the main take home here is post-infection, right? Post-infection, red blood cell casts, low C3 after a recent URI, and post-streptococcal glomerulonephritis until proven otherwise, okay? Nephritic is not nephrotic. Inflammation dominant is the picture here. So that's what I want you to know. So basically, we're talking about a kidney problem post-acute infection. And the reason I give you this is to make sure that you have a sufficient index of suspicion when you see patients in the outpatient setting or wherever you happen to see them. Now, It's important that we choose wisely. We don't just want to take a rapid shotgun approach to testing everyone for everything, okay? So test selection in kidney disease should always flow from the question, what problem am I trying to confirm and how will the result change the management? So you start with a serum creatinine, BUN electrolytes, and an estimated glomerular filtration rate. This is the thing that sets the stage for quantifying kidney function. And then urine analysis with microscopy, as you can see, has been indispensable. It's the single most informative low-cost test for localizing renal disease. Then you do your functional tests, looking at the fraction of excreted sodium or fraction of excreted urea if they're on diuretics. And you're looking at urine osmolality and specific gravity, also very useful. And then you're going to look at things like the protein assessment, right? You're going to look at urine albumin creatinine ratio in standard screening tests for CKD. Maybe you'll do a 24-hour urine. If it's not responding or you still have abnormal protein that's not albumin, that's when you're ordering SPEP and UPEP. Do not neglect the issues of imaging. Renal ultrasound is the first line modality. It will tell you about the kidney structure, hydronephrosis, obstructions. If you need to, CT or MRI when you suspect stones, masses, cysts, or vascular abnormalities. And then special serologies, if you're starting to go down the path of inflammatory pathways like rheumatology, don't forget about the ANA and the double-stranded DNA. Don't forget infectious disease, HIV, hepatitis, and the like. And of course, it all ends in renal biopsy to get the definitive answer. But in short, you're starting with these simple high-yield tests to help focus in and build a trend. So when they move to the next level of care, you can give a good pattern. Okay, so when you're faced with a kidney dysfunction, you use this structured algorithm, right? Confirm the renal dysfunction. Is the creatinine truly elevated? Is there a baseline for comparison? Is the GFR reduced? Is the urine output diminished? Right? Less than 400 milliliters a day is what we're talking about for oliguria. That's pretty low. Um, Oh, we consider it anuric, just FYI, if it's less than 100 a day. But this person's not the one walking around in the community. The other thing you want to do is distinguish acute kidney from chronic kidney, right? By looking at the timeline. Acute is days to weeks, chronic greater than 3 months. You want to look at older labs, older imaging. If you get to the acute kidney phase, then you are going to do this fraction of excreted sodium and you're going to take a look and see if you have findings consistent with the tubular, interstitial, or glomerular damage. If the fraction of excreted sodium is greater than 2, it's muddy brown. And also you need to consider postrenal factors in the acute kidney patient. And of course, you always want to identify any life-threatening disturbances and treat them first. You don't want the patient dying before you finish the workup. So make sure you're treating along the way and relieving those modifiable risk factors. So the very first thing you consider yourself is acute versus chronic. That's the first question you need to ask yourself. Everything else flows from that distinction. If you get it wrong, you might miss acute kidney injury that's reversible. All right. So let's see here. We want to think about syndrome, time, and course. So start with the syndrome, the pattern of findings that points to the part of the nephron or the renal system. The glomerular, proteinuria, hematuria, red blood cell, cast, edema, sometimes hypertension. That's the classic nephritic, nephrotic syndrome. You want to look at tubulo-interstitial, that's muddy brown casts, acute tubular necrosis. We're looking for white cells, impaired concentration ability, and electrolyte derangements. Remember to consider severe hypertension or signs of end organ damage. That will give you indication of a vascular problem. And don't forget about the urine microscopy. All right, so the first step is when you manage, you want to stabilize the patient first, check the potassium, the acid-base balance, the fluid status, and the signs of uremia. Hyperkalemia and acidosis will kill you quickly. Treat them immediately. Pulmonary edema and uremic pericarditis are considered major red flags. Always correct the reversible factors. especially with respect to volume, and remove any excess volume overload. Don't put them in pump failure and wonder why the kidney is now failing. Relieve any obstruction, catheterize, stenting, discontinue nephrotoxic drugs, and tailor the treatment to the syndrome. So if it's glomerular disease, often immune mediated, manage with immunosuppressive agents, high dose steroids, cyclophosphamide, rituximab, under nephrology and possibly rheumatology consult. If it's tubulointerstitial disease, remove the offending drug, treat the underlying infection, provide supportive fluids and electrolyte management. If it's vascular disease, control the blood pressure aggressively, anticoagulate if it's thrombotic, and consider revascularization. Maybe renal artery stenting will be in order. Postrenal, obviously, immediate decompression is the only effective therapy, so just keep that in mind as well. Okay, let me give you some lifespan considerations here now. So renal disease doesn't look the same at every age. The lifespan context will shape both the vulnerability and the presentation. So some creatinine levels mean very different things, say at 6 months old, pregnant women, 80-year-old. So you have to recognize the age and stage when you consider renal insufficiency. So take a look here in pediatrics. So in pediatrics, kidney disease looks very different. So you may have things like congenital anomalies, malformations like renal dysplasia, hypoplasia, obstructive uropathy. These are the leading causes of kidney disease in children. And many are detected prenatally because they do that full anatomy ultrasound. And long term, these things will drive a lot of things like growth impairment and chronic kidney disease. There is a condition called hemolytic uremic syndrome. There's a classic triad that goes here. There's microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury. The most common trigger for this, we've said this in another lecture, so you may see this, is the E. coli Shiga toxin producer. And it often follows a diarrheal illness. So management in this case is supportive. Dialysis may be required acutely, and neurological complications can occur due to microthrombi. So this is sad because the kid is actually having mini strokes, essentially. There's another condition that can develop, post-streptococcal glomerulonephritis. Typically, this will follow pharyngitis or impetigo infection. This presents with edema, Coca-Cola colored urine, red blood cell casts, and hypertension. Complement 3 levels should be low, but usually should recover in weeks. And most children will fully recover, unlike some adults, they may not. And I told you earlier about minimal change disease. This is the most common cause of nephrotic syndrome in children. It's characterized by massive proteinuria, hypoalbuminemia, and edema. The pathology, though, is very subtle because you may have some effacement of the podocyte foot process on electron microscopy. That's what they will tell you. So the reason I use those words, it's not like you're looking under the microscope. It's when you see these words on a report, it's supposed to trigger your mind to go down this path to investigate and refer. Treatment here is highly effective with corticosteroids. Prognosis is good. So pediatric kidneys have very little physiologic reserve. They decompensate quickly when they're injured. But if the insult is reversed early, they have a better chance of recovery. So take a look at this 6-month-old here with acute kidney injury after vomiting and diarrhea, and the exam shows lethargy and dehydration. And so let's decode the labs we have here. So even small rises in infants are significant since the baseline levels are very low to begin with. Hyperkalemia and metabolic acidosis. This is because the impaired kidney cannot excrete potassium or hydrogen effectively. The urine findings, the low sodium and high osmolality, indicate that the tubules are intact and appropriately conserving sodium and water. This makes this consistent with a prerenal pathology. So infants have immature nephrons and very limited concentrating ability. They rely heavily on fluid intake. So even short periods of vomiting or diarrhea can cause severe hypovolemia and a rapid decline in the GFR. So the management priority here is to stabilize immediately. Airway, breathing, circulation, EKG for hyperkalemic changes. You want to correct volume depletion with cautious IV fluid replacement. You want to address any electrolyte abnormalities, and you want to monitor urine output and reassess the renal function frequently. Obviously, avoid nephrotoxic agents, aminoglycosides, which can convert prerenal to intrinsic. And infants, you have to know, have a narrow reserve. So what looks like a little gastroenteritis in an adult can push the baby into dangerous, toxic, acute kidney injury in a matter of hours. So rapid recognition and rehydration can fully reverse prerenal acute kidney before it progresses to tubular necrosis. UTI, vesicoureteral reflux. This is also one of the most common serious bacterial infections in children. The VUR is a major critical predisposing factor. Infants and young children may not present with classic dysuria or frequency. Instead, what you'll see is they'll have fever, irritability, poor feeding, and vomiting. Now, in febrile infants, a UTI should always be considered because untreated infection can ascend and cause renal scarring. So the most common pathogen, by the way, as you might guess, is E. coli, which accounts for about 80 to 90% of cases. Vesicoureteral reflux is an abnormal retrograde backflow of urine from the bladder into the ureters and sometimes high up into the renal pelvis. Now, this happens due to congenital defects in the ureterovesicular junction, and this is what predisposes them to a UTI like pyelonephritis, because bacteria can gain easier access to the upper urinary tracts. So over time, the pyelonephritis in this patient can cause renal scarring, hypertension, chronic kidney disease, and the like. So your first febrile UTI child under 2 years old warrants a renal bladder ultrasound, and if VUR is suspected, then they get a voiding cystourethrogram, and that's the gold standard test for diagnosing this condition. Acute UTI, prompt antibiotic therapy tailored to the cultured results. Every pediatric UTI should raise the question, why did this child get it? If it's recurrent, febrile, severe, always make sure there's an evaluation for structural or functional abnormalities because the goal is to prevent the long-term dysfunction. So with kids, when managing pediatric renal disease, the focus is on early recognition and reversing the damage. And remember to include the family in the care. Always treat febrile UTIs promptly with appropriate antibiotics. Less than 2 years old, first UTI, renal bladder ultrasound. Have an index of suspicion for nephrotic syndrome. It's most common in pediatrics that present with edema, proteinuria, hypoalbuminuria. And the first line therapy for them is corticosteroids. It typically responds rather quickly. If they're nephritic, then you're considering post-strep glomerulonephritis or hemolytic uremic syndrome. That's who gets supportive care, salt and fluid restriction, diuretics, antihypertensives, and the like. If they have congenital anomalies, usually they're early detected by ultrasound, and they're going to need surgical correction. All right, now let's talk about renal disease in pregnancy. So, pregnancy profoundly changes kidney physiology, and recognizing what's normal versus what is pathological is essential so we don't pathologize normal. So, glomerular filtration typically will rise by about 50% by mid-pregnancy, and this lowers the baseline serum creatinine by 0.4 to 0.6 milligrams per deciliter, and that means a creatinine of 1 may be normal in a non-pregnant woman, but abnormal in pregnancy. So mild proteinuria, less than 300 milligrams a day, can be normal due to increased filtration, but more than that suggests pathology. So urine risks to consider: preeclampsia, so if they have new onset hypertension, proteinuria after 20 weeks gestation, sometimes with end organ dysfunction, CNS and liver kidney damage. This is the leading cause of maternal and fetal morbidity. Another thing to consider is HELP syndrome. You may have heard of this, but we'll review it. Hemolysis, elevated liver enzymes, and low platelets. This is a dangerous variant of preeclampsia that can cause acute kidney injury and multi-organ failure. Other causes of acute kidney injury in pregnancy include things like hyperemesis gravidarum, which causes volume depletion because it's a poor perfusion state, septic abortions, or obstructive uropathy. So kidney stones in pregnancy can be a major factor here. When CKD pre-exists in a woman that's pregnant, women with CKD enter pregnancy with a higher risk of preeclampsia, preterm birth, fetal growth retardation, and progression to full kidney disease. So if you watch Steel Magnolias, she goes into renal failure after she gets pregnant. That's the movie you can watch to help bring this into mind. The lower the baseline GFR, the greater the risk of adverse outcomes will be. So what do you do for these people? We want tight blood pressure control to improve both maternal and fetal outcomes. We want safe agents, including things like labetalol, nifedipine, and hydralazine. What do we avoid in pregnant women? ACE inhibitors and ARBs. These are teratogenic and contraindicated. Frequent monitoring of maternal renal function, proteinuria, and fetal growth is kind of what you'll do along the way. So if you work in adult primary care and you supervise pregnancies, these things should be on your radar. Definitely multidisciplinary. If this is their factor, they're going to be in maternal fetal medicine is ideal. These are high-risk pregnancy patients. So in pregnancy, the take-home message is always recalibrate your reference points. A creatinine of 1 is too high. Mild proteinuria can be normal. Hypertension plus proteinuria after 20 weeks is never benign. It is preeclampsia until proven otherwise. So blood pressure and protein handling change during pregnancy, but there are clear lines between physiologic adaptation and pathology. Blood pressure typically decreases in the first 2 trimesters due to systemic vasodilation, but then it drifts back towards the baseline in the 3rd trimester. Protein excretion increases slightly because of higher GFR, but should stay below that 300 milligrams a day. If there's a hypertensive disorder like gestational hypertension, this is new onset hypertension after 20 weeks without proteinuria or systemic features. That's the definition. Preeclampsia is when you have hypertension plus proteinuria greater than 300 milligrams a day, or evidence of end organ dysfunction or renal insufficiency or liver dysfunction or neurological symptoms or thrombocytopenia. That is preeclampsia's clinical definition. Eclampsia has the preeclampsia, except now it's complicated by seizures. And chronic hypertension with superimposed preeclampsia. This is a woman with pre-existing hypertension who develops new proteinuria or worsening hypertension after 20 weeks. So what you want to pay attention to here is remember, the creatinine in pregnancy of 1 should be considered abnormal because baseline levels fall even when small increases suggest significant injury because there's more fluid volume, so we expect it to be lower. Significant proteinuria is never just a normal protein, never normal physiology. It always needs to be investigated. Okay. So remember, hypertension after 20 weeks is preeclampsia until proven otherwise. Don't get out of this class and not know that, okay? Red flag should at least be very common. So let's take a look at this 28-year-old pregnant woman with a blood pressure of 166 over 110 and proteinuria of 2 grams, headache and edema. This is pregnancy-related acute kidney injury. This remains a major cause of the mortality. And so take a look here as to the manifestation. Notice the elevated liver enzymes and the low platelets. What we're diagnosing here is essentially HELP syndrome with acute kidney injury. Now, the question here is delivery timing versus maternal fetal risk. So this is definitely a person that's going to be in high-risk OB, maternal fetal medicine, but this is the anticipatory guidance and the referral points that you can still be involved with. Preeclampsia and HELP syndrome are 2 of the most dangerous pregnancy-related conditions for both mother and fetus, as they are the most major causes of acute kidney injury in pregnancy. So Preeclampsia is, remember, new onset hypertension after 20 weeks gestation plus proteinuria. HELP syndrome, the acronym kind of describes what the condition is, and what we're trying to prevent is eclampsia, okay? And we want to preserve renal function. Definitive treatment for this condition is delivery. So this is the scheduled C-section and or induction person. How early can we get the baby out without compromising both mom and baby? So what you want to do in pregnancy is manage the blood pressure with pregnancy-safe agents, monitor closely for HELP syndrome. Definitely, it's a multidisciplinary approach. And just note the nuance of proteinuria after 20 weeks warrants the further evaluation there. All right, let's talk about the elderly and bring this thing home because most of us will be dealing with the elderly. So in the elderly, renal physiology changes in pretty predictable ways that make them uniquely vulnerable to kidney disease. So the main thing in the elderly is glomerular filtration declines about 1 milliliter per minute per year after age 40. Glomerular filtration declines 1 milliliter per minute per year after age 40. Renal plasma flow then also falls. Nephron numbers decrease as a result, and that leaves you reduced nephron reserves. The tubules will lose their ability to conserve sodium and concentrate urine, and this is why older adults are more prone to dehydration and hyponatremia. Hyponatremia is the most common electrolyte derangement in hospitalized patients. So let's move on. So look at this here. We have a 78-year-old man with hypertension, coronary artery disease. His creatinine is between 1.2 for years, which might look normal at first, but his GFR is only 42. So this puts him in the stage 3 kidney disease, chronic kidney disease. Creatinine generation is low. The serum creatinine may look deceptively normal, but kidney function is much worse when you calculate GFR. Now, here are the complications we have here. Hemoglobin of 10.5, right? It's chronic kidney disease. Maybe the erythropoietin production is low. Calcium is 8.1, phosphate 5.4. We have the elevated PTH and chronic kidney disease here. So what you're basically looking for are the downstream effects of what this person may be manifesting. Creatinine alone is not reliable in the elderly. You always want to look at the GFR, and that's what you will renally dose the medications for. Okay, let's talk about sarcopenia because this is the age-related loss of skeletal muscle. This profoundly affects how you assess kidney function. Less muscle means less creatinine production. So a serum creatinine of 1.0 in a frail 80-year-old may reflect a GFR of 30 to 40, while the same creatinine in a muscular 25-year-old could mean a GFR of well over 100. This leads to the under-recognition of CKD if you rely on creatinine alone. That's why we use GFR equations and in some cases a test called cystatin C, which is an independent of muscle mass. So cystatin C is this test that's going to help you evaluate renal function to help distinguish from muscle mass. Sarcopenia is not just lab artifact, by the way. This reflects malnutrition and inflammation and reduced physical activity, all of which are poor prognosis in the elderly. So you should know that this is the reason for the creatinine you're seeing. Medication dosing in the elderly is always targeted toward the GFR. There's high-risk medications include NSAIDs, contrast agents, ACEs, and ARBs. So use a GFR calculator when renally dosing your medications. And of course, the elderly rules start low and go slow. Always double check the renal clearance and avoid nephrotoxic agents when possible, and monitor therapeutic drug levels at the trough when you're checking. Okay, let's put this all together. We're going to wrap this up shortly so we have time for the review. So take a look briefly here. Let's do a quick case. So we're going to compare and contrast. So there are 3 cases up on the screen here. You've got a 6-month-old who comes in with vomiting, diarrhea, decreased urine output. The most likely mechanism of the acute kidney injury here is going to be prerenal. And so we're going to treat that underlying cause. In this 28-year-old with septic shock, right, which kind of acute kidney injury is most likely? Most likely intrinsic, usually acute tubular necrosis in this setting. And what's the finding that drives this home for you? It's the muddy brown granular casts. That's the sloughed off tubular cells. And what's the tell here is the fraction of excreted sodium is going to be greater than 2, and they can't reabsorb. If we look at case 3 of the 78-year-old female here, elderly person, normal creatinine, but it's 1.2, right? That's the baseline. So here we are at 2.2 to 3.5. What we have to worry about in this elderly person is the sarcopenia masking the chronic kidney disease and, of course, the risk of polypharmacy. So the goal for all these up here, by the way, is to say to you, never rely on creatinine alone in the elderly. Check the GFR and look for the CKD complications. What these 3 cases should tell you is that across the lifespan, the kidney variabilities change. Infants will crash fast. Young adults will show classic acute tubular necrosis. The elderly will look deceptively normal by creatinine. So what you're looking for is syndrome, time course, and that will help you make sense of this. How long has it been going on, and what helped it develop? So here is the syndromic workup across the lifespan. When a patient presents with elevated creatinine, the very first step before you think of imaging is the clinical context. Pediatric, pregnancy, adult, geriatric. The same creatinine means different things at different ages. In peds, what are the most common renal concerns? Congenital anomalies and urinary tract infections. They're evaluated by ultrasound and UA culture to determine what the underlying cause is. In pregnancy, the renal complication should always be top of mind. Preeclampsia, HELP syndrome, right? Basic tests can point you there. Blood pressure, proteinuria, liver function, that will open up where we're going. Creatinine of 1 in pregnancy is not normal. GFR typically increases. And for your average adult outside of pregnancy, how do you start thinking about kidney disease? By syndrome. Is it glomerular, tubular, vascular, or postrenal? And which tool is going to be most helpful? That's going to be labs and imaging, and sometimes biopsy for definitive diagnosis. In the geriatric population, the serum creatinine can be misleading because of sarcopenia. This lowers creatinine production, so the number can look deceptively normal. That's why you want to look at GFR instead. And your 4 syndrome buckets are going to be glomerular, proteinuria, red blood cell casts. Tubular, electrolyte imbalance, acidosis. Vascular, hypertension, ischemia. Postrenal, obstruction, retention. Good? 4 buckets. You get those 4 buckets, you could breeze through a nephrology opening salvo. So when you see elevated creatinine, history, physical, labs, and you're looking for acute kidney, chronic kidney, or acute on chronic, the fraction of excreted sodium will help point you in the right direction. And let's see here, major casts in microscopy. There you go. This is just a good slide to have for easy reference. If I told you urine microscopy was like a liquid biopsy, because it provides immediate diagnostic clues as to where in the nephron the problem is happening. And here is your chart. 1 through 1, 2, 3. Just follow along. Start with the basics, history and physical, classified by time and course. Acute kidney injury is abrupt rise in creatinine in days to weeks. Chronic kidney disease greater than 3 months. Acute on chronic, there's an acute decline in the background of chronic kidney disease. Think syndromically. Is it glomerular? Proteinuria, hematuria, red blood cell cast. Is it tubular? Electrolyte derangement, muddy brown cast. Is it vascular? Malignant hypertension, ischemia, microangiopathy. Postrenal obstructions, hydronephrosis, fluctuating output. Always consider the lifespan, what's unique to pediatrics, pregnancy, geriatrics, and manage the main things first. Stabilize life-threatening conditions, electrolytes, fluid volume, and control the blood pressure. Are there any questions now about renal before we get to the midterm review? I've spent you all. I could see the people just barely trying to keep themselves upright. God bless you all for a 3 hour, 2.5 hour lecture, crash course in nephrology. No questions on this? All right, I will stop the recording here.